Hello everyone and welcome to our final discussion of the day. We have a huge topic to unpack over the next hour. Is the elimination of neglected tropical diseases possible? Now please enter your questions on the screens over the next hour, and as usual we'll be leaving some time at the very end to try and get around to one or two questions at least. Francois Schwappi is the head of the Division of Tropical and Humanitarian Medicine over at Geneva University Hospitals, and he's going to be leading us throughout this discussion over the next hour. I'll leave it to you now.
Thank you very much, Olivia, and welcome everyone. So I'm not a professional journalist, but I saw that they actually prepared cards, so that's why I prepared cards as well. The topic of today is the elimination of neglected tropical disease possible. Is very timely. Last week at the 73rd World Health Assembly, the WHO has launched its new roadmap for neglected tropical disease, and of course we will come back on that topic during this session. So it will be organized like this. We will have a short presentation of this new roadmap after my general introduction, and then we will have a series of questions that we will discuss and debate with our panelists, and then there will be some space for questions at the end from the audience. Neglected tropical disease, as they are called, they mainly occur in the tropics. Not exclusively, but mainly. By far. It's a vast panel of conditions. There are now 20, and they are neglected. Neglected by whom? Neglected by all stakeholders, by farmers, by ministries of health, in the international community, by the academics, by the media, even though it was so dark about 20 years ago. Now the situation is much lighter thanks to the effort of all these stakeholders. To have grouped these diseases together has been really a super smart idea because to put together the rich public health burden that is quite similar to what is the case for AIDS, for malaria, or for tuberculosis, at least in the same logarithm. That really helps to gather funding for control programs, that really helps for advocacy purpose, and it really helps also to gather funding for research. But one downside of it is that this group of neglected tropical disease is very diverse. It is made of very different disease in terms of frequency, in terms of case fatality, etc. And so it is not that easy to bring simple messages. It's not that easy to control this whole group of neglected tropical disease with single interventions. And it was certainly not easy for the WHO to come up with a roadmap that includes all these panel of disease. So I would like to introduce our first panelist, Dr. Mwele Malesela. She's the director of the Department of Control of Neglected Tropical Disease at WHO. And Dr. Mwele, we would like to hear you about the main achievements of this first roadmap that covered the period between 2012 and 2020, and of course to give us an introduction of this new roadmap that will cover the period of 2021 to 2030. So welcome, Dr. Mwele.
Thank you very much. Thank you very much for the opportunity to speak today. And just to speak about, like you said, it's a panel of 20 diseases which are all debilitating and keeping people in cycles of poverty, and are very much linked to poverty and economic growth So we are, as WHO, we are extremely proud that the second NTD roadmap has been just passed recently by the World Health Assembly. The first roadmap was focused on 5 strategies, focusing on preventive chemotherapy, on intensified disease management, on vector control, on WASH, and there has been great progress. There has been tremendous progress since this roadmap was launched in 2012. First of all, I think the roadmap was followed by the London Declaration and had this great opportunity of bringing partners together to focus on at least 10 of those diseases. So we have made progress in mainly the preventive chemotherapy diseases. We have made great progress. 17 countries have eliminated lymphatic filariasis. Countries, about 199, several countries have eliminated guinea worm. Disease. We know that we only have a few countries left. We have about 4 countries left with guinea worm. We have less than 1,000 cases of human African trypanosomiasis, and that's very exciting given the numbers that were there in the year 2000. We have the elimination of dog-mediated rabies in Mexico. We have a number of countries that have eliminated trachoma. And so the progress has been really good overall. Even with this progress, even with the progress that we see now, we still have not gotten to elimination by 2020. And I think that is the thing that made us, as WHO, think, how do we move forward? How do we move beyond? Because the idea, the strategies were there. But what would help us move from these strategies that we have? We were focusing. The first roadmap focused on vector control. It focused on WASH. It focused on preventive chemotherapy. But how do we actually bring this together? And I think the idea now of the new roadmap was, let us see how we can, first of all, integrate the diseases and not have diseases that are more favored than others. Let's try and make sure that all diseases at least get some attention. And this is why we kind of have focused on integration, integrating the diseases or where we can work together, integrating within the health system, mainstreaming within the health system. We've also, so that is the first major shift of the roadmap. The second major shift was multi-sectoral action. So even if we have a strategy on WASH, we have a strategy on vector control, we have a strategy on One Health, if we can't bring them together, we're not going to make progress. So the idea of the roadmap, again, of this second roadmap, was to kind of push for multi-sectoral action. And then the third major shift, which is the main one, which is why these programs were going to be sustainable well after some of the funders have maybe stopped supporting them, is country ownership. And that's the fundamental shift of the whole roadmap, making sure that, first of all, we have country ownership, and we have good sustainability plans for countries to make sure that they can, that these programs can succeed beyond the time when we still have donor support. So it's a combination of those 3 things, which is really what is making this roadmap unique and our focus unique. So we are taking all the strategies which have worked well before, but as individual strategies, and trying to bring them together in comprehensive strategies that will make the actual changes as we move forward. Thank you.
Thank you so much for this introduction with a past view over the first roadmap period and introduction of this new roadmap that was so awaited. Let me now introduce the 3 other panelists. I would start with Dr. Ami Falngao. She's the Global Health Medical Lead for Africa at Sanofi. She's currently based in Dakar. Hello, Dr. Ami. Dr. Nathalie Stroop-Voorgraft. She is the NTD Director at the Drugs for Neglected Tropical Disease Initiative, based here in Geneva. Welcome, Nathalie. And Professor Philippe Guérin, who is the director of the Infectious Disease Data Observatory at the Oxford University in UK. Hello, Philippe. Let me go now to the first question that I would like to discuss with you, in particular first with you, Nathalie Stroop-Voorgraft. Question is, what are the gaps in disease knowledge and existing tools to diagnose, to treat, and cut transmission of neglected tropical diseases, and that could jeopardize elimination? And perhaps we could rephrase it a bit like, don't we have all the tools now, and should we now just spend all the energy and resources in scaling up and accelerate the programmatic action, as it is one of the pillars of the new roadmap? Nathalie.
Thank you, Dr. Chapuis. I wish you were right. It would be nice. I think we're very happy to celebrate diseases that have been eliminated. We're extremely happy to celebrate the successes. But I don't think anyone here would think that job is done and that we have all the tools we need to reach the objectives of the 2030 roadmap. Maybe I can illustrate with a few of the diseases that DNDi is working on. For sleeping sickness, we're very happy. We have a good new oral treatment, and we may have another single treatment that may come. Still, we need to go through very sophisticated parasitic research to identify the parasite. We need a tool and a rapid diagnostic test that will have all the specificities and sensitivities to be able to detect the last case, and we need a treatment that will be able to be administered to those patients. So R&D is definitely needed there. There's also some improvement in tracking the tsetse flies that have been put in place, but they need to be deployed. And further, we need sentinel monitoring to make sure that when we say it's finished, it's really finished. But we have the tools to do that. So we need those tools. For leishmaniasis, for example, or for Chagas disease, we know that it takes, at least for Chagas, it takes some time for the disease to develop. We don't have the proper tools to understand how the disease develops, who will be sick, who will not be sick. How do you measure the fact that you have an effective treatment? And how do you also convince that treatment can be deployed large scale? How do you treat mothers who will transmit to their children? How do you take care of parasites that may be staying for a long time in the body? How do you measure that? How do you tackle that? The same in leishmaniasis. How would you make sure that no one will develop post-Kala-Azar dermal leishmaniasis, which is a skin disease? And by the way, how do you diagnose this skin disease, which could look as other tropical skin diseases? So a lot of diagnostics on the skin, and WHO, in fact, has set up a skin disease group now because it's an entry point. So there are some diagnostic questions. The tools we have, the treatments we have are not all field adapted. Some are very toxic still. Some have very poor efficacy. Some are only symptomatic. So take the example of onchocerciasis, a very large and super effective mass drug administration program with ivermectin, which works when the program can manage to treat and to deliver every 6 months the treatment. But it's not treating the root cause. The root cause is an adult worm that produces all the baby worms targeted with ivermectin. Maybe having a treatment for the adult worm would facilitate things. You would give it once and then it's finished because the adult worm lives for 15 years. So, there are many examples like this. So R&D is needed here definitely to have the tools that will bring a solution by 2030. And I think I can give finally the example of mycetoma, for which there is not even enough understanding of disease transmission. How do you get mycetoma? We know patients get sick. We help and prevent if we don't even understand the mechanism by which they get sick and they get this terrible disease. So I think I'll stop here for now, but I would say that a lot of R&D again is needed. Test, diagnose, understand the transmission, understand the evolution, and then monitor that you have eliminated the disease.
Thank you, Nathalie, for this very convincing piece of advocacy. I'd like to get the opinion from the other panelists. Dr. Ami, we can't hear. We can't hear you. Please.
You can hear me?
Oh, yes, now we can.
My micro is open. You hear me?
Yeah, it's fine.
Yes, I just want to add that it's important also for identification and treatment of cases. So the capacity, the health workers' capacity building is also key to attend the elimination. And also another thing is population awareness. Because it's very, very difficult to reach the last cases. So I think that it's very important to engage population so that we can screen them so that they can participate, to be really engaged on the fight and understanding why it's important to eliminate this disease. They are not all at the same steps as said Nathalie, but I think that capacity building is also really important.
Okay, thank you. R&D clearly still needed. Is it also your opinion, Professor Guérin? We can hear you. Please switch on the mic.
I'd like to echo Nathalie. Yeah, all right, sorry. I'd like to echo Nathalie's opinion, but first of all, we don't need the same thing for all the neglected tropical diseases, and imagining that one tool will fit all is surely wrong. But there is one thing that all the neglected diseases have in common. It's the lack of data and the lack of evidence. So we are, even for the current therapy that we are using, or the current diagnostic tool that we are using, we have limited evidence to sustain why this tool is good, and is it good for the entire population. We have very limited data, for instance, on pregnant women, on small children, and this lack of evidence is an issue when we go to the last phase of elimination of a disease, when we are getting to the point where it's the most complicated cases that we will have to deal. And I believe that this investment that we will have to do to finish the last mile, as has been referred to by many, is going to be not a small investment. It's going to cost more per patient to be treated, and we need to be clear about that. I think it will be wrong by saying it's going to go away, the investment that we need to do, because it's not the case. In order to do the job for elimination, which has been demonstrated for smallpox and now for polio, actually you need a sustained investment and a sustained research to get the job done up to the end.
Professor Guérin, and actually it's my second question that I would like to submit to you is precisely the economic cost of elimination or eradication of some of the neglected tropical disease, not for all, of course. Are they justified in comparison to just keeping them under control under a certain public health burden threshold? Dr. Ami, perhaps you would like to elaborate on that.
It's open. Yes, thank you. I think that it's a really very relevant question. To answer this question, I think that health economic specialists should be more precise in terms of data. But from my point of view, even it's true that last cases are the most difficult to reach and need more efforts and funding. At the end, elimination will cost less than keeping them under control. For me, because we learn from the fact that a rebound is always possible if interventions are not maintained. For control, we need to continue interventions, and the rebound will be cost for me much more, as we will lose years of effort and investment if you have more cases. And the other problem is that with the low number of cases, priority shifts to other disease and decline in donors contribution are possible. Knowing the weakness of low and middle income countries' health systems with insufficient domestic finding, focusing in 2030 roadmap NCDs for elimination is the best thing to do. And it's also important to notice, as Professor Phillips said, that even if elimination is reached, continued action is to prevent re-establishment of transmission may be required. I will let other speakers complete as other elements must be considered. I think it's a real question to ask, but I think that the choice is already done with the roadmap. For sure, we are going in the way of elimination.
Thank you, Dr. Ami. Dr. Mwele, do you concur with this opinion?
I absolutely do. I absolutely do, because I definitely, Dr. Ami has a very important point there about, first of all, the issue of rebound. But first of all, let's look back at places where it was not elimination, it was high-level control, but we have been able, we're now moving towards elimination. And one disease is onchocerciasis. And Natalie talked about the lack of tools to address the adult worm. But even where we are with onco, there are several areas in West Africa which have been kind of reclaimed from the black fly. And people have been able to invest. There's been economic development because of the issue of high-level control and now moving towards elimination, just knowing that it's possible. So I think the other thing that we're beginning to understand from health economics, the health economists, and particularly this recent presentation on the gains following possible elimination or elimination as a public health problem of schistosomiasis and soil-transmitted helminth, actually gaining countries, giving them a higher GDP a higher GDP by 2040. So we're talking about 5 billion increase in GDP in 4 of the countries that were studied. So, I think this issue of also looking at the economic benefit of these programs and having more studies, because I think this is the first kind of study of its kind of projecting the increases in GDP, and that's why the NTD community is quite excited by this. So I think it's a great starting point for discussion on apart from the initial gains that Dr. Ami talked about in terms of the interest, the country's ability to maintain high-level control. We've seen there's been so many rebounds of so many diseases that were actually felt to have been controlled in some of the countries. And so I think the elimination is the way to go. But as Professor Philip then said, the issue of surveillance, monitoring and evaluation, keeping countries investing in this and putting this in their sustainability plans is very important. And I think we've addressed all these issues in the NTD roadmap.
Thank you, Dr. Mwele. Professor Guérin, would you like to add something?
Maybe a final word on the economic impact. So, to some extent, we are asked to do more with less money with NTDs, which is challenging. We need to do more innovation with less resources. I think one of the problems that we would have to face is that although we clearly understand that we need an integration of the of the programs of entities which would be more transversal. And fair enough, probably maintaining vertical program for less than 1,000 cases today of human African trypanosomiasis is not going to be reasonable. Having said that, we need to retain the expertise and expert opinion to guide those programs. And I think as an academic, I'd like to make a plea that this is not going to happen by magic. A lot of the expertise that today we are benefiting for this program is based on years and decades of expertise of colleagues who know very well the disease and the biology of the disease. We need to maintain that. And this will require an investment also on the academic side to ensure that some young researcher will continue to study this disease. And unless we do that, all the investment might be wasted, and we will lack guidance in some years if we don't pay attention to this particular issue.
Yes, indeed. This is striking to see how these diseases are often not part of curriculum, and I could even start with a situation here at the Geneva University where we are stuck with optional courses that teach about these conditions, which are very present even here in our countries, either imported conditions like Chagas disease in Latin American migrants, but we even have neglected tropical disease that are transmitted here, like alveolar echinococcus or some intestinal helminths. Let me switch to, you mentioned several times already this notion of surveillance. So in the context of weak health system, so what is the opportunity to design sentinel surveillance system to follow the neglected tropical disease elimination drive? In other words, how can we improve surveillance system in a context of limited resources? Professor Guérin, maybe I would rebound and ask you this question first.
Yeah, thank you. So sentinel surveillance is one of the tools that we have, and we need to look at it more as a tool in a toolbox. It's not gonna do magic. It's gonna do and provide some information in certain situations and for certain diseases. Again, Chagas, human African trypanosomiasis are regional issues dealt at regional level, where visceral leishmaniasis or cutaneous leishmaniasis, schistosomiasis, salt-transmitted elements are touching various continents. So how do we coordinate that, and how do we provide information which are captured in one continent that could benefit others? The idea of sentinel site are interesting if we want to monitor, for instance, over time, the efficacy of a treatment in the context of a potential antimicrobial resistance, or if we want to capture information about pharmacovigilance. Are those new drugs that we are implementing now safe, and can we capture information that could guide us for their future use? Sentinel site will be very suited for doing that. It won't give us information about the epidemiologic dynamic of a disease. It won't give us information about access to treatment. It won't give us information about specific population. And so let's keep it as an interesting new tool, or an interesting tool which can be deployed for various entities, but possibly not as the solution, a cheap solution that will solve all our problems.
Thank you, Philippe. Any one of the panelists would like to add something? Dr. Mwele.
So I think surveillance systems are the key, and in one of the groups that I wanted to talk about earlier was the Diagnostic Technical Advisory Group. And within that, we also have a group that is going to be a cross-cutting group that's going to be dealing with surveillance, so that we talk about diagnostics in the context of both testing, but also looking at them in the context of surveillance and trying to understand what is the use cases that we need for particular surveillance. So I definitely agree that here, as we move forward, as we move towards elimination, surveillance becomes the real key investment for countries, and to give them the most practical surveillance tools that they can use in these systems, which are, as you say, they are quite weak. So strengthening surveillance has to be has to be contextual, and we have to think about what are the tools that can really be used to ensure that we do good surveillance in countries where systems are not strong enough to hold very sophisticated surveillance systems. So we have to, can we use, are there better systems of data management, data capture? Can we use community health workers? Can we, I think we have to be broader in our thinking about what surveillance will entail, particularly in these countries. Thank you.
Thank you, Dr. Mwele. Dr. Nathalie, you work for the Drugs for Neglected Tropical Disease Initiative, so mainly in the field of new drug development. But I suppose that sometimes the lack of diagnostics, either for surveillance to gather data or for confirming the presence of disease, is an obstacle also for new drug development. Is that the case?
Oh, absolutely. It's the case. I think it's the case for patients that there is delay between their first symptoms and time to reach a center that is very specialized for all of these diseases. These are very specialized teams that are looking and assessing and diagnosing patients. For leishmaniasis, you do bone marrow aspirate, so not everyone knows to do how to do a bone marrow, but then you have to look at the bone marrow. So it's something that's less invasive, that's earlier. Clearly, we also need tools to verify early on that we have efficacy. That's another aspect. But to come back maybe to the sentinel sites, I think in the future the danger is that we feel that we've come to a very low number, and then we don't need to. We can put our activities and the money to something else, and we all know it's wrong. And because health resources are so precious and scarce, there is a need to bring them together and go towards some kind of, I wouldn't say horizontal, but joint when it's applicable, as Dr. Mwele said, regionally. Look at, for example, in DRC, we've started working with the national program that deals with onchocerciasis and the one that deals with sleeping sickness. In some areas, they are looking at the same villages. So when they do some kind of research for cases, they could do it for both diseases. And slowly, but probably surely, we will transfer knowledge from one group to another in a kind of very favorable way that brings value to all. Because the risk is also, we were discussing this during a HAT session, that the knowledge of these hyper-specialized lab technicians disappears, vanishes. That's not possible. So these sentinel sites, they need to be, knowledge has to be transferred to those sites. And maybe someone that was working on one disease will learn to work on another one and another one and another one. But we can't lose this expertise. I think we have to be very vigilant about this.
Yeah, it's certainly a very important point to keep this expertise alive. Dr. Ami, would you like to add something on the topic of surveillance and keeping expertise alive with a mic?
Yes, just to say that it's really important at this stage. And we all know, and I think the roadmap has shown that despite advances, monitoring and evaluation of TDs remains a challenge in many countries. And it's very important to improve data collection and management and reporting. I think that surveillance can help on that. So a strong sentinel surveillance system should be put in place and should be standardized in for the monitoring in all countries. I think it's very important, and surveillance may help also to adapt interventions and decision making. I think it's really important at this step because we need to be focused on what happened locally. We need to think globally, but we need to act locally. So for me, surveillance is a great tool because can really help to measure progress, but also to evaluate to do a post evaluation and evaluation surveillance. And to talk about medicine, I think it's also important for monitoring drug efficacy and resistance and pharmacovigilance. For us as pharmaceutical industry, it's really important to integrate this. So surveillance is key to attend elimination.
Thank you very much. I have the next question is, you mentioned several times also during this discussion, this importance of integration, but also the importance of cross-cutting approaches. And this is something that is very prominent in the new roadmap. It's not that new, this will to find synergies between program, between activities, and sometimes it kind of stays on paper. Dr. Mwele, could you tell us about some successful examples of cross-cutting approaches or some very promising ones that you had in mind when this new roadmap was in the making?
Thank you very much, Dr. Shakwi. I think the idea, I'm going to give two examples. So one example is the intersection between animal, human health, and the environment. So the One Health concept, and actually trying to link, because if we look at the NTDs, 50% of the NTDs actually have some connection with animals. And without linking with programmatically with the animal, the livelihood, and the environment people, we are losing an opportunity to fight these diseases at all fronts. And so that is one of a promising area that we're working on. We have a webinar also tomorrow to discuss how we're going to be moving forward with this. But it is an area that we have been pushing a lot in this new roadmap. And we are also going to have a specific strategy, which is going to be a companion document to the roadmap, which will focus on One Health and what we need to do in countries to promote, to engage, to make sure that the NTD program engages with the people working on animal health, population livelihoods, and the environment. The second one is the one Natalie mentioned on skin NTDs. So this has been a great opportunity to bring together NTDs whose major point of intersection is the skin. And there are many of these. So again, there are several of the NTDs that we are working on that have this skin component, and we are looking at them as skin NTDs. So we're looking, when we're now talking about diagnostics, we're looking at what are the kind of diagnostics which can be used to actually differentially diagnose some of these skin conditions. How can we use artificial intelligence to allow us to make these diagnoses? How can we better plan programs that will allow us to look at these diseases in a more comprehensive way? So those are just two examples of ways that I think we can do better in terms of integration and move it from paper to action. Because when you go down in the countries, when you go to the lowest level, when you go to the district, when you go to the villages, these programs are not really that separate. So the separation happens at global level, it happens at the sub-regional level, and sometimes at the country level, at the national level. But the further down you go, the more integrated work is. So I think we have an opportunity to use this and move it forward. Thank you.
I would like to hear also the other panelists on that particular topic. Dr. Natalie.
Mm-hmm. Yes, thank you. Again, I think I just mentioned the example of regions in DRC where you have coexisting onchocerciasis and you have also sleeping sickness. But we could also think of an entry point being fever and a coupled diagnostic like is being developed by another PDP find who are developing an RDT that would look at the same time at malaria and HAT. Imagine that, sleeping sickness will be forgotten, we hope, maybe in a way, in a few years, but there might be still cases. So if every time a patient comes with fever, we verify that it's not HAT, that is fantastic. So that's a kind of, transversal collaboration. Another one that is very also neglected is mental health. All of these diseases have an impact on mental health. They are very stigmatizing. They bring a lot of anxiety or depression or sometimes suicide, either because patients suffer from intolerable rashes and pruritus like they do in onchocerciasis, or because they become very bizarre for their family, they are excluded, or because they are just suffering from so much pain and economic impact and everything that it's really depressing. It's not words. And we need to understand and care about this and address this a little more, but because it's going to be for the neglected diseases, maybe we'll have more attention on this. That's one of the examples I can think of, but there are many more.
Yeah, your last example is very relevant. We experience this now with the COVID. We have a bit neglected during the first wave, the mental health impact of the infection and also of the overall COVID atmosphere. But this is really something that becomes very prominent. Dr. Ami, I feel that you would like to add something.
It's exactly the example I wanted to give, because we are working in the field of mental health, and I think mental health is quite a neglected disease. It's not well funded, and there is a big stigma, and I think that it's really relevant to create this connection with neglected tropical diseases, because it's a big problem, a big issue, and I think that there are many areas where they can be connected, and we can really gain time and also I can say social impact, and it's very important for patients' quality of life and being. And for sure, for me, limited resources should push us to pull efforts together. Effective intersectoral collaboration is key. We need to collaborate to improve the quality and cost effectiveness of interventions. I think that through the collaboration, entities can benefit from resources and activities of other more funded sectors, because it's not the same funding in all disease areas. So I think that it's important to use to help other areas of disease to put them together with another program well funded. And for me, vectoral control is also key. And at the example that Natalie gave, malaria and HAT, because we are working on this field also, I think it's definitely an opportunity to make the two programs together for vector control.
Thank you, Dr. Ami. Professor Guérin, do you have anything to add on all these good examples of what integration should look like?
A lot have been said by my colleagues in between. Dr. Mwele mentioning a One Health approach, our colleagues mentioning the fact that we need more integration between pharmaceutical industry, the programs, the PDPs, the policymakers. The role of facilitation of WHO is critically important. The global health landscape has been changing a lot in the last 30 years. We need to admit that. And working together has not been always, let's put it frankly, has not been always easy. But I think we need to, and in the context of neglected tropical diseases, bridging all these different actors are critically important. One maybe last comment I'd like to make in the thinking of an integrating approach more from a vertical program to transversal approaches. That's absolutely probably needed for some of the diseases. We need to make sure one thing is that when we are asking and moving in that direction, we don't make the people who are currently working in vertical programs redundant. We need to have a plan to integrate them into the health system, because what will be their incentive to get rid of a disease if at the same time losing their job? And I think this is an aspect which has been seen elsewhere in the context of malaria, of polio, where we need to learn from these experiences and take it on board and learn from that knowledge for NTDs. But working together, what choice do we have to do anything else? None. So that's going to be really, I think, the key aspect of the success.
Yeah, I agree with that, yes. Thank you so much. This was a few questions that we had pre-prepared, but we have received a few questions from the audience that I would like to invite Olivia to come. And I see that there are 3 questions.
Yes, let's see how much time we have and how much we can get around to. So the first question from the audience is, do you think that the attention directed towards COVID-19 will undermine efforts to eliminate NTDs? So a big question, but very relevant. So who would like to take this on first?
Yeah, I was a bit expecting this question because we all have it in mind for sure. Maybe public health aspect, Dr. Mwele first.
Thank you. Thank you. I think that question is very relevant, and we are seeing, so in April, we asked countries, particularly, for example, that were doing mass drug administration, to stop doing mass drug administration. So programs actually came to a screeching halt. The programs where people needed treatment through the primary healthcare system, those ones went on, but again, they had to be delivered safely. So it's only in July of this year that, again, we have kind of asked countries to resume programs. And to resume them safely, to do, first of all, a risk analysis, a risk-benefit analysis, and analyze the mitigation factors and carry out the programs. So we really saw that even in this place where there was a gap, programs really were moved 2 years behind. So there is, and some models have said, if this continues into this, if this was to continue into December or early January next year, some programs would actually go behind 2 years back. So we will be going 2 years back. So we do have, so with NTDs, this is a serious focus, and even funding. We're seeing people talk about funding, funding COVID, but I think we have an opportunity. First of all, we have a system, delivery systems, which use the community. And these have been very important in COVID. And so I think this is another place where we can be opportunistic and take the opportunities from COVID to try to push for the NTD agenda and NTD programs. But you're right that they will be impacted. They've been impacted in delivery of medicines. They've been impacted in delivery of the program itself. And so I think we just need to look at what can we do moving forward, particularly with how can we take advantage of the platforms that are created for NTDs to support COVID programs as we move forward, but at the same time to ensure NTD programs do not fall through the cracks.
Okay, thank you very much. Good to hear that there is also an opportunity side in the discussion. I would like to hear also, Dr. Nathalie, to see how much it also impacts funding for research of new tools. Because there is a lot of funding that is directed towards COVID, of course. Does it impact?
Yeah. It's a difficult question. Well, our funding, we don't get funding for 6 months or 1 year. So thankfully, we have funding that is more of 2, 3, or 4 years. So we are currently still seeing that we have funding for our activities in the next 2, 3 years. But I think there's a threat. Yes, there's a threat that pandemic diseases will get more attention because people. As Dr. Mwele has said it, I cannot say it better than what she has. I think showing successes, having this roadmap with clear objectives, with bringing attention to the fact that there is misery outside COVID, but there's also COVID and NTDs are connected. I think we have to make the link, but it's a difficult period for NTDs, and we have to continue the focus. I think how to do it is not the easiest to respond to, but we have to continue, because what we've seen in the history of some of these diseases is that when you release attention, meaning you release tools, meaning you release funding, they will reappear. And one day they will reappear, and they might become more important in terms of prevalence than they were before. So it's not healthy not to invest in NTDs. That's how maybe we should phrase it.
Thank you. Yeah, it's a difficult year for almost everything, perhaps, but except for home delivery of food or things like this. We have a second question from the audience.
Sure. And this question, I think I would love the panelists to give a very concise answer, because it's relatively straightforward. And it's which NTDs can be eliminated in the coming years?
So I would say eliminated with zero transmission or eradicated. I would translate a bit the question like this. Dr. Mwele?
I couldn't hear the question.
Sorry, excuse me. The question was, which of the NTDs is subject to be eliminated, zero transmission, or eradicated in the years to come?
I think we are all experiencing hearing you.
Oh, now I can hear you. Yes.
Okay.
Can you ask the question again?
Okay, sorry, I don't know what's going on. Sorry about this. The question is, which of the 20 NTDs is subject to be eliminated, zero transmission, or eradicated in the years to come?
Which of the NTDs can be eliminated by 2030?
Or in the years to come?
Is that the question?
Yeah. That's a question from the audience.
Okay, I mean, it's I'm not going to pin myself to a wall and say that this and this will be eliminated. What I will say is that what we have in the context of developing the roadmap, one thing that we said where we were going to be very serious was the monitoring and evaluation and tracking progress. So we would ensure that whatever program we have, if we have better tools as we move along, we will change the strategy. If we have poor tools, we will also go back and revisit our targets and say, were we thinking realistically about 2030? We probably need to change the target. Now, there are some people who say, oh, if you start changing the target, it will be, it will be a problem. But I think we need to be really realistic about the road to 2030. And having these checks and balances years that we're going to see in 2023, 2025, and 2028, really looking at where we are in the context of these diseases, I think will allow us to say, will allow us to look. So we are making, for example, trachoma is one NTD which I think really is on its way. Immediately I would think of trachoma, LF, and heart moving towards 2030. But then there are definitely others which I think we need what this tracking system of really intense monitoring and evaluation followed by country-led surveillance, I think will allow us to get more. But I think if I say we're going to eliminate this, and this off the top of my head, I'm pinning myself to a wall. And in 2030, I do not want to be put on the spot. But it's true. I mean, in 2012, they said most of these will be eliminated by 2020. Here we are in 2020 with major progress, but we're not quite there yet. So I think this is why for us, really the monitoring and evaluation is really, really key in ensuring that we really take seriously the progress we're making, analyze it, and be realistic about it. Thank you.
Thank you. I don't think we need to elaborate more on that. Let me try now to wrap up a little bit the discussion we had in this last hour. Definitely, when NTD enters into the WHO list of NTDs, it's already in itself a first step towards elimination. We know that the next steps might take decades of time, but we have seen, even with the most recent one like snake bites, how that changed the landscape, and how it is. We changed the scale of getting resources for operational programs and for research, etc. What we discussed today is that clearly research and development remain extraordinarily useful and in need, not only to develop new diagnostic and treatments, but also new surveillance tools, and a new way to gather data and epidemiological data from sometimes. The objective of elimination, even though we may not always have a lot of cost-effectiveness data available, but the few ones that come up are promising, and it's clearly an investment that is worth making. And there is more than an economic benefit to have this ambition to eliminate some of these diseases from the planet. But once again, this surveillance tool that we don't always speak that much when we speak about public health and disease control is very crucial, as well as transferring knowledge to the people who are in charge of this surveillance. And one way to maintain this knowledge is also to expand it to other conditions, other diseases, to have this cross-cutting approach, as it is well emphasized in the new roadmap. And finally, this cross-cutting and integration approach, it is, as you said, Dr. Mwele, time to go from paper to action. There are really already initiatives on the way. There are things that are already being done, and this is a way to go. And as Professor Guérin said, in fact, working together, there is no choice. We have to work together. There is this absolutely need to integrate the effort into the existing systems, to reinforce these systems, and to have all countries increasing their investment, and also these control on all these NTD initiatives, and this is also well emphasized in the new roadmap. I certainly miss a couple of points. I hope you'll forgive me, and I hope the audience got as interested as I was in this session. We really would like to thank you very much for attending, participating, and sharing your knowledge. Thank you so much, all of you, and thank you, the audience, and thank you here also, the technical team. Thank you, Olivia, and I wish you all a good evening or a good day, depending where you are, or good night. Bye-bye.
So thank you very much to all our panelists. Goodbye and take care. And also thank you so much, Francois, for breaking all those points down. I know that you had a lot of notes that you wanted to go through, but that was a very concise conclusion. So thank you very much for that.
Thank you.
Ladies and gentlemen, once more, big thank you to you for joining us. It comes down to the end of day 2 of the 2020 Geneva Health Forum. We've covered so many topics today, from traditional medicine, sleeping sickness, digital health, and now to tropical diseases. And that's just to name a few. Tomorrow, we have an equally diverse and varied program planned for you. So if you want to catch that, please tune in, same procedure as usual, at 9:30. And we're going to focus on decolonizing global health. Take care, stay safe, and we'll see you shortly. Thank you.
Thank you.